If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we're going to cover what to do when we encounter a high hematocrit, including initial assessment, follow-up and management, always focusing on what is relevant in primary care only. I have based this episode on Haematological guidance by Camden CCG, Manchester Foundation Trust and King's Health Partners. The links to them are in the episode description. Right, let's jump into it. And we will start by saying that hematocrit measures the proportion of blood volume taken up by red blood cells. It can be expressed either as a percentage from 0 to 100 or as a decimal proportion from 0 to 1. Because it reflects the relative volumes of red cells and plasma, the hematocrit is influenced not only by the absolute number of red blood cells, but also by the amount of circulating plasma. Any change in either component will affect the final value. A high hematocrit raises the possibility of polycythemia. Polycythemia can be diagnosed when the hematocrit is greater than 0.52 in men and greater than 0.48 in women. These thresholds help identify affected people, but they do not, by themselves, tell us the cause. Polycythemia is sometimes referred to as erythrocytosis, but this is not entirely accurate. Erythrocytosis specifically refers to an increased number of red blood cells in the circulation. Polycythemia, on the other hand, is defined by a raised hematocrit, not by a direct count of red blood cells. As a result, it is possible to have a high hematocrit without true erythrocytosis. This distinction matters because there are two types of polycythemia. The first is absolute polycythemia, where an increased red cell mass is genuinely present, that is, true erythrocytosis. The second is relative or apparent polycythemia, where the hematocrit is high, not because there are more red cells, but because the plasma volume is reduced. Dehydration, diuretics, or plasma loss can all create this picture, leading to a raised hematocrit despite a normal red cell mass. It is also common in obese men, and it is also associated with smoking, alcohol, hypertension, and stress. Despite the potentially reversible causes of relative or apparent polycythemia, these patients are also at risk of occlusive vascular episodes. On the other hand, we have absolute polycythemia, which reflects a true increase in red cell mass. This can be divided into primary and secondary causes. The primary cause is polycythemia vera. Well over 90% of patients with polycythemia vera have an acquired mutation in the JAK2 gene, which plays an important role in regulating erythropoiesis. Because of this mutation, the bone marrow becomes hypersensitive to growth signals and produces red blood cells even when erythropoietin levels are low. In other words, these patients do not need as much erythropoietin to drive red cell production. The main features of polycythemia vera are therefore a positive JAK2 mutation test, and a low serum erythropoietin level. Polycythemia is also commonly associated with low ferritin because the accelerated and unregulated production of red blood cells consumes large amounts of iron. Being a myeloproliferative disorder, polycythemia vera may also show raised white blood cells and/or platelets, reflecting the involvement of the bone marrow. Secondary polycythemia, on the other hand, results from a physiological increase in erythropoietin production. The kidneys release more erythropoietin in response to reduced oxygen levels, so secondary polycythemia can be an appropriate response to chronic hypoxia, as seen in COPD, congenital or acquired heart disease, and in smokers. It can also be an inappropriate response when erythropoietin is produced by tumors, such as certain renal or liver tumors, or even uterine fibroids, which can secrete erythropoietin autonomously. Other possible causes of secondary polycythemia include anabolic steroids and testosterone therapy, as androgens stimulate erythropoietin production through hormonal pathways. In cases of secondary polycythemia, the pattern is different. The JAK2 mutation test is negative, erythropoietin levels are high, and ferritin, white blood cells, and platelets are normal. So what do we do when we receive a high hematocrit result? Well, criteria for urgent referral are a hematocrit greater than 0.6 in men or greater than 0.56 in women. We should also refer urgently if the patient has had a recent thrombosis, shows any abnormal bleeding, or reports neurological or visual symptoms. These features raise concern for hyperviscosity or an underlying myeloproliferative disorder, both of which require immediate specialist assessment. If the criteria for urgent referral are not met, the next step is to confirm the result by repeating the blood test. In order to differentiate between apparent and absolute polycythemia, the blood sample should be taken without a tourniquet, and we should ensure that the patient has not been fasting, is well hydrated, and has been advised about alcohol intake and smoking, as these factors can artificially raise the hematocrit. In this repeat blood test, we should request a repeat full blood count to confirm whether the raised hematocrit is persistent, and to check for associated abnormalities in white cells or platelets, a blood film which can reveal morphological clues to myeloproliferative disease or other hematological disorders. We should also screen for diabetes, hyperlipidemia, and hypertension, as these cardiovascular risk factors often coexist with secondary causes of polycythemia and may contribute to vascular complications. As mentioned earlier, we should also check ferritin to assess iron stores, which may be depleted in polycythemia vera due to increased red cell production. And finally, renal and liver function tests, since kidney or liver disease may also contribute to secondary polycythemia or influence erythropoietin production. Additionally, if we suspect absolute polycythemia, the following tests should be done: genetic testing for the JAK2 mutation and erythropoietin levels, which help distinguish primary from secondary causes, being low in polycythemia vera and elevated in secondary polycythemia. However, in the UK, JAK2 mutation testing and serum erythropoietin levels are not routinely available in primary care. In most areas, these investigations are carried out by hematology teams as they form part of the specialist workup for myeloproliferative disorders. And therefore, if absolute polycythemia is suspected or the hematocrit remains persistently elevated, the appropriate course of action is to refer the patient to hematology, who will then arrange the JAK2 and erythropoietin testing as part of their assessment. So let's summarize this patient's management again. If we encounter someone with a high hematocrit, we will see if they meet the urgent referral criteria, that is, a hematocrit greater than 0.6 in men or greater than 0.56 in women. We should also refer urgently if the patient has had a recent thrombosis, shows any abnormal bleeding, or reports neurological or visual symptoms. If the urgent criteria are not met, we will repeat the full blood count and arrange routine screening investigations. Criteria for routine referral are an unexplained persistently elevated hematocrit above 0.52 in men or above 4.8 in women, taking into account that referrals should be considered at lower thresholds if there is associated iron deficiency. Persistently means at least 2 readings above these thresholds, taken 4 weeks apart. Alternatively, routine referral is also justified if the hematocrit is above 0.52 in men or above 0.48 in women without waiting for a second test, if there are associated symptoms of concern such as pruritus, a raised white blood cell count and/or platelets, splenomegaly, or if there is a past, not recent history of arterial or venous thrombosis. From a clinical perspective, we will suspect apparent polycythemia if there's a history of factors such as dehydration, smoking, alcohol excess, diuretics, or other causes of hemoconcentration. We will suspect absolute secondary polycythemia if there is chronic hypoxia from conditions such as COPD, smoking, or cardiac disease. if the patient is taking anabolic steroids or testosterone therapy, or if there is a possibility of erythropoietin-producing tumors. If none of these clues is present, we may be dealing with absolute primary polycythemia or polycythemia vera. These patients should be referred to hematology, since confirming the diagnosis requires tests that are not routinely available in general practice. So that is it, a review of the initial assessment and management of a high hematocrit. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.